So with that, we're going to move on to, we're going to have a discussion about post-endothelial keratoplasty complications management. Dr. Sam Garg and Dr. Barry Lee will lead us off with that. So, Sam.
Okay, wow, this bright lights. My name's Sam Garg from UC Irvine, talking about DMEK rebubbles. Who does DMEKs in the audience? Who's had to rebubble a patient? That's why they asked me to do this. Okay, here are my financial disclosures. So I'll start this with a case, 72-year-old male, status post DMEK for Fuchs. I used 20% SF6, preloaded graft with an S stamp, uncomplicated surgery, post-op day 1 fully attached, post-op day 5, visual acuity not improving, and a partial detachment was noted. So when do you rebubble? Well, you should have a low threshold for rebubbling when there's more than 30% of the area separated, if it's in the if the visual axis is affected, and if there's curling and progressive separation noted. Sometimes we see them, or those will stick back, you know, they might sort of zipper back up, but if you see it progressively going the wrong way, you want to have a low threshold to go in and intervene. Make sure the graft is oriented correctly. There's a reason there's an S stamp. You want to make sure the S is in the correct orientation. Sometimes it's not. Anterior segment OCT can be helpful, and you can get sequential testing. Remember that the graft curls endothelium out, and when you look at your anterior segment OCT, you can see here, right there, that this graft is going the wrong way, right? So this one was upside down. This one came from Dr. Chamberlain at OHSU. This one you can see here, that patient, go back. This is another patient, there's a detachment here. You got the anterior segment OCT, and you can see serially, so centrally attached, peripherally not so well attached. This is that same patient, and so different images, different areas of the cornea just to show this was sort of a diffuse detachment. So we felt like we wanted to go in and rebubble here. So what you need, I do this at the slit lamp, so topical anesthesia, betadine, an eyelid speculum. I have 2 30-gauge cannulas available, 2 3cc syringes, some BSS, and topical antibiotic. Certainly you want to get informed consent for these patients, make sure all your supplies are there. Last thing you want to do is be ready to go and then have to run and get something and come back. Place your speculum. I put betadine, I do a betadine prep. It's not a full betadine prep, but enough so I'm just covering the area. Topical antibiotic. I prepare my cannulas, one with air, one with BSS as a backup. I think the key for me with rebubbling is making sure that you release some aqueous. Oftentimes people just go in and inject. You're really going to get the eye really firm if you do that. So I go in, I release some aqueous, make sure that you're positioned comfortably, especially if you're going to do it at the slit lamp. So if you need a little support for your elbow, do that. Also make sure that the syringe is not fully inflated with air, because then your finger won't be able to get to the end of the plunger. So I sort of go halfway with that. You don't need that much air to do this. Assure that the cannula is behind the graft, and then gently insufflate. You don't want to push real hard. You want to gently insufflate firmly, but slowly. Confirm that they have vision after this is done. Check their pressure, topical antibiotics, put them on their back for a little bit. And here's an example of a graft that's in the correct position. You can see here the air bubble post rebubble in the clinic. And then this was our patient who then reattached after rebubbling. And post-op month 6 after rebubble, they can look indistinguishable from each other. Thank you.
Yeah, so we'll do a little discussion right now.
Yeah, so I have a quick question. So do you, when you rebubble, first of all, do you do it in the minor room, or do you put the patient back in the chair? Do you use any topical, hyperosmotic drops?
So I do it at the slit lamp almost 100% of the time, and then I'll lay them back in the room, sort of go see a patient or two, 5 to 10 minutes, and then come back.
An hour later.
Yeah.
Question: when
you but no hypertonic, no Muro or anything. I don't think it works that quickly, and the effect is going to be more from the tamponade than the hypertonic.
Do you rebubble with air or with a repeat SF6?
Yeah, so we do it in the clinic, so I just do it with air. Yeah, because otherwise then you have to get the canister and make sure they have the right concentration.
Go Do you think it's worth removing the epithelium if it's very edematous? Do you think that impedes sort of the flow of fluid out?
No, I mean, it might take them a little longer to heal, but no, I don't think so. And then it adds one more variable with respect to infection and whatnot as well, so I generally don't.
What happens if you've detached and
It's a lot of questions, guys, come on.
What happens if you get a curl in the graft and like?
Yeah, so
where
great
do you approach
question.
that?
So sometimes if you go in the wrong spot, you'll get like a fold in the graft. If the fold is peripheral, I say leave it alone. I don't think it's worthwhile to go in and try to evacuate the air and then fill it with BSS and then redo it. If the fold is central, you have to go in, remove the air, fill with a little BSS. Sometimes, massage it a little bit and then go in again and place your air.
Great talk, Sam. The only thing that I do differently is I use a 30 gauge needle to add the air. And I just do that because I also do it in the slit lamp. But I mean, the patient tends to move,
Yeah.
a little antsy, and it's harder to keep that cannula just perfectly planar within the wound. So if you have that, I've lost chambers before. So
Sure.
if you have a 30 gauge needle, I feel like the patient can do all they want, and you're going to keep the chamber stable. So.
Yeah, so usually, it's being done in the first week or so we have access to the paracentesis. And then I find it hard to release aqueous through the 30 gauge needle. So I always release, so at the paracentesis, I'll push on the paracentesis, decompress the eye.
Yeah, I release, but I'm saying I add air through the 30 gauge.
So you go in twice? Yeah, so I just try to go in once.
Sometimes ergonomically it can be hard to actually do that with the needle attached to the syringe. Chris Salas in Iowa has a great YouTube video about how to do this ergonomically by putting a butterfly needle, attaching it to IV tubing, and then holding the syringe in your hand that's controlling the slit lamp joystick.
Yeah.
So your one needle on the butterfly syringe is in the eye, and then you have a lot more mobility. The patient's not going to move.
That's a good
great
idea.
YouTube video.
One other option that works sometimes that can help with the ergonomics is kind of what Zach was saying. Take a TB syringe, use a 30 gauge needle, just use 0.15 cc's of air. So the plunger is quite low, and don't even go through a paracentesis, especially if it's like 2 weeks out and you can't find it.
Yeah.
Just make a clear corneal puncture, put in that 0.15 cc's of air. You don't have to release anything. It creates a bubble that's basically the exact size of the graft. Lay them supine, and then as you have some aqueous turnover, you get a bubble that's the right size. Because for DMEK detachments, you don't need to hyperpressurize, right? You just need to have apposition of the air to the graft.
I think that's a key point. It's not a pressure game, it's a size of the bubble game and covering the graft and the defect.
And just one comment from the audience, you need to check the patient after the rebubble of the slit lamp to make sure there's a small fluid meniscus so that you don't go into pupillary block, as you would primarily.
Yeah, so I'm primarily for these, for DMEKs, we're putting PIs in all of these patients, so less chance of that to begin with. But,
Just one,
yeah.
it's, even though it's a little bit painful, I would put Pilo, especially while you're getting used to it, just so that you are actually across the AC, across the iris plane, versus, directing it towards the pupil, especially if they're dilated, because then it's much easier to get under the iris, and that creates such a mess. So if you know you've got a good PI, then just go ahead and constrict them before you do it, so you get used to just going across the iris plane.